Welcome to the weekly ECG cases. My name is Tharindu Uyanage from Geelong Emergency Department. This is a short video to highlight key features of this ECG, remind ourselves about basic pathophysiology and management of this patient. This is a 40-year-old male who presented with palpitations for 24 hours. He did not have any significant past medical history and his systolic blood pressure was 130. So he was very stable on presentation. So this is his ECG. So the key features of this ECG are got an irregular broad complex tachycardia, and his morphologies are changing constantly, and his rate is approaching 250 to 300. So the top differential diagnosis for this ECG would be AF with WPW syndrome, right bundle branch block with AF, and polymorphic VT. Let's see how we could exclude the last two differentials. I would say it's not right bundle branch block with AF due to two reasons. So firstly due to rate, secondly due to his varying morphologies. So in atrial fibrillation, rate can be maximally 180 to 200 because your AV node is blocking or killing most of the atrial conduction that comes to the AV node. So in our patient, rate is approaching 250 to 300. So without an accessory pathway, it can't be just AF. So, and the other thing in AF with right bundle branch block, your morphologies will be constant. So in our patients in V4, if you concentrate on V4, you can clearly see there's almost beat to beat variation. So that's why I say this is not AF with right bundle branch block. Why it's not polymorphic VT? In polymorphic VT, you would expect your axis to change regularly. In our patient, axis is constant, so it's very unlikely to be polymorphic VT. So we treated our patient as AF with WPW. So we thought the safest option would be to DC cardiovert the patient. So he had 200 joules of DC cardioversion under procedural sedation, and this is his post shock ECG. Now we could please see clearly that there's short PR interval, delta wave, and a wide QRS. So he's in sinus rhythm now with WPW syndrome. So I have given three simple diagrams to understand or simplify the pathophysiology. So this is patient when the patient is in sinus rhythm, they have the bundle of Kent, which is a bypass tract which bypasses the AV node. So you wouldn't see usual PR delay because the usual PR delay is due to your AV node delay. So you have short PR, but the conduction through the accessory pathway is slow. So that's why you have upslurring upstroke in the beginning of the QRS and a wide QRS. So this is when they're in sinus rhythm. They're usually very asymptomatic at this stage. There's so this could be incidental finding or patient comes post syncope to emergency department and now they're in sinus rhythm. You can see this ECG features. So let's see what happened when they go into SVT. So patients with WPW syndrome or extra pathway can go into um, orthodromic or antidromic SVTs. So which means for example in this diagram, so the conduction is going down the AV node, down the his bundle Purkinje system and coming back up through the accessory pathway. So this is an example of orthodromic SVT. So this AV node and your accessory pathway makes an electric circuit and the rate is very fast and usually it causes a narrow complex regular tachycardia. It can be other way around. Electricity can go down the accessory pathway can and come back up through the AV node, which is an antidromic SVT, in which case it could be a broad complex SVT. Both these conditions, if you're sure it's a regular tachycardia, you can block the AV node with adenosine or beta blocker or a calcium channel blocker and break the circuit, and patient will return to sinus rhythm. So the third diagram is to show what happens if the patient suddenly goes to AF. For example, in our patient was initially in sinus rhythm and then he went suddenly into AF. So in AF, the atria is beating from 300 to 600. So now we have the accessory pathway and the conduction will come through. There's no AV. When the conduction coming through the accessory pathway, there's nothing to kill the beats like AV node. So the most of the conduction will go through the accessory pathway, and you will still have the AV node to kill some of the beats. So this is a deadly condition because your accessory pathway is now giving way to most of the atrial contractions to come down, and the ventricle will fibrillate at the end. So we need to act quickly, and safest option would be to DC cardioversion. If you're thinking of chemical cardioversion with flecainide, it would be a good idea to talk to your cardiology colleagues. All right, so that's hope that three diagrams help you to understand the pathophysiology. So to take the main take-home points from this case would be in atrial fibrillation with WPW. So the key ECG features are the ECG is irregular, and it's broad, and morphologies are changing. Rate can be approaching 250 to 300, and the safest option would be to DC cardiovert the patient. Thank you very much.